Hi, my name is Grant Magana, and today we're going to talk about how to read an arterial line blood pressure, as well as some minor details about the setup. So first things are objectives. Today we're going to talk about what an arterial line is, why we use them, some supplies that you need when we're going to insert it, how we actually obtain the arterial line blood pressure, and then what you need to actually read it, so some terms on that. So first of all, what is it? The arterial line is a catheter, much similar to an IV, that we insert into an artery, and it is essentially a continuous blood pressure, meaning we can always have an idea of what a person's blood pressure is. And why would we want to use one of those? Well, there's really two main reasons. The first reason would be after like an extensive cardiac surgery. Very important in those cases to keep a very close eye on a patient's blood pressure. Depending on what their blood pressures do, you may need to adjust medications and whatnot. And then the second reason that we can use it is for patients who just are, for some reason, having low blood pressures consistently, meaning they're not able to get their blood pressure levels up on their own. And usually in those cases, we require medication called vasopressors to essentially clamp down everything and help your heart kind of pump maybe a little better, or just to kind of constrict all your veins so that your blood pressure goes a little bit higher. So during the process of getting an arterial line, there are generally two people involved, either a doctor or an advanced practice practitioner, and the RN, excuse me. So the MD or APP will have usually a kit that comes with everything they need, but generally they need an arterial line catheter, sterile towels, sterile gloves, and then depending on if they're going to do it via ultrasound or if they're going to do it with just feel or palpation, they can do it that way. And we want to make sure that this is done sterilely. And then for the RN, as you can see in this upper box, there's a few things that we need. So there's a pressure bag, a bag of 500 ml saline. We need the tubing that goes from the saline to the patient, and then there is also on there what's called a transducer, and we have a cable that connects from the transducer to the monitor. So the first job is the MD or the APP is going to choose the most appropriate site. Generally, in most patients, we're going to do the radial artery. It's the least invasive, but also very accurate. There's plenty of other sites that we can choose, just depends on the patient and what they can and can't handle. Usually we'll observe those sites with an ultrasound just to see which one's going to be the most appropriate. And like I said previously, it's a sterile procedure, so we want to prep the site sterilely. So sterile towels go over, we're going to clean it, and then with either ultrasound or palpation, during sterile technique, they're going to insert that catheter into the artery there. And then once that is completed, the MD or APP will attach the tubing from the nurse's set to the patient. So once the doctor or APP has connected your tubing as a nurse that you set up to the patient, the nurse's job is basically two things. We're going to make sure that there is an appropriate waveform on the monitor, so making sure that you're capturing a patient's blood pressure essentially. Now, when that first pops up, you're not going to have any numbers, so it's very important for us to go on and do what is called zeroing the line, and that's when we measure up this transducer that you see to the phlebostatic axis, and that is essentially fourth intercostal space, about nipple line, and that's basically to ensure that we have equilibrium and that it's going to get us the most accurate blood pressure. And I have a short video here to show you how we do that.
How to zero your line.
Hopefully that gives you a little bit of an idea of how it works. Now that we've set up our monitor and everything, let's talk about the little parts about reading. So there's three numbers involved that we generally pay close attention to: your systolic, your diastolic, and your MAP, or your mean arterial pressure. Your systolic is your higher numbers, so that upper waveform, and that's when your heart pressure or your arterial pressure is the highest after your heart is contracting and ejecting. Your next number, those low numbers of that waveform, are your diastolic numbers. These are essentially when your heart is refilling, so there's not a lot of pressure. And then your MAP, or your mean arterial pressure, is based off of a calculation of your systolic and your diastolic. It's actually really important and actually is a better calculator of tissue perfusion for patients. So we actually prefer to use this number whenever we are using an arterial line. And generally for most patients, we want to keep that number at 65 or above. So when we zero a patient's art line, what we're doing is performing a square wave test during all of that as well. And really the importance of that is kind of just understanding, is your arterial line going to be overdampened, underdampened, or is it going to be normal? You can kind of see from this graph here what is good and what isn't good. So essentially, if it's overdampened, essentially you don't have a little notch, you are just kind of flat, and that's going to give you a mistakenly low blood pressure. And then when you have a bunch of those notches in there, that means that it's underdampened. And that means that you're just going to get a little bit of a higher blood pressure. But even in those cases, a lot of times that mean arterial pressure that we talked about can still be pretty accurate, even if you are over or under dampened. You just want to pay really close attention that you're zeroing your art line appropriately. You're paying attention to those waveforms and know what you're actually looking at. So in conclusion, today we talked about what an arterial line is, why we use them. So why would we use them specifically? Like I said, blood pressure monitoring in very critical situations. Talked about how we're going to set up with the MD and ABP, what they need, what the nurses need, what we're going to do to zero that art line and make sure that we're getting the best reading. Talked about what your systolic, diastolic, and your mean arterial pressure are, and we just briefly touched on what can be some misreadings, but making sure that we're paying attention to the best numbers and making sure we're understanding what our waveforms actually mean. Here are my references, and thank you for listening.